Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be covering anger and aggression, and this is going to be maybe a three-part series. But before we get started, as always, I'm going to ask you to please support me and support my channel by liking this video. You're going to love it. Press that like button now so you don't forget, please, and subscribing to my channel if you haven't done so already. Don't forget, I have audio lessons available on my website, nexusnursinginstitute.com. So let's get started. Again, aggression and what am I teaching on? Anger and aggression. So let's look at neurotransmitters. Neurotransmitters, especially serotonin, dopamine, and GABA. These three play a vital role in anger and aggression. I know what you're thinking. You're like, okay, well, serotonin, Professor D, I thought you said serotonin was a feel-good neurotransmitter. That's what's given for patients who have depression. Well, yes, but guess what? It also does play a vital role in both anger and aggression. Look at this. Serotonin can inhibit, that means to stop, to delay. It can inhibit and stimulate aggressive behavior, depending on the part of the brain that's being measured. So it can stop aggressive behavior, but it can also stimulate aggressive behavior. Dopamine's impact on reward-seeking behavior may increase aggression. When you think of dopamine, usually you think about what? Parkinson's. You know, in Parkinson's, patient doesn't have enough dopamine, right? But dopamine also has a part in anger and aggression. Like serotonin, dopamine can sometimes enhance aggression and sometimes reduce impulsivity that leads to aggression. And last, GABA. GABA, the main inhibitory neurotransmitter, may reduce aggressiveness. Its absence may increase impulsivity and aggressive responses. So make sure that you guys understand these three neurotransmitters. Now, let's move on. Predictors of violence. Look at this box. Predictors of violence, signs and symptoms that usually, but not always, precede violence. Hyperactivity, most important predictor of imminent violence. And they give you examples. Make sure you know those examples because you may see them. It's a very high chance that you see this on testing. Pacing, restlessness. You see a patient pacing back and forth. They're restless. They're doing this or they're doing this. You better watch them closer, right? That may be a symptom that they're about to be violent. Increasing anxiety and tension, clenched jaw or fist, rigid posture, fixed or tense facial expression, mumbling to themselves. What do you think they're mumbling? I'm about to knock this nurse out. Who do they think they're messing with? You better pay attention. Verbal abuse, them using profanity or being argumentative, or them actually, threatening harm. Loud voice, change of pitch, or very soft voice, forcing others to strain to hear. Stone silence. Intense eye contact or avoidance of eye contact. I'm not going to go over all of them, guys. I just went over the ones that tend to show the most on nursing tests. So make sure you guys look through this entire box, pause it if you have to, and you can recognize those potential predictors of violence. Assessment guidelines for aggression and anger. Look at this. A history of violence is the single best predictor of future violence. Patients who are delusional. What does delusion mean? That means to have a false belief, right? Patients who are delusional, hyperactive, impulsive. What does impulsive mean? That means they don't even think about the consequences of their action. The minute that thought comes into their head, they do it. Okay, so patients who are delusional, they're hyperactive, they're impulsive, or predisposed to irritability are going to be at a higher risk for violence. Three major factors associated with violence can be assessed with these three questions. These questions. Make sure you know what those questions are. Do they have a wish or intent to harm? Do they have a plan? Do they have means to carry out that plan? This should sound familiar to you guys, right? If we even suspect a patient is suicidal, what is the first thing that we ask? Are you having thoughts of harming yourself or someone else? As nursing students, here where you go wrong. You think that asking them that question is planting the thought in their head, and it's not. You have to assess them for violence towards self or someone else. So the first thing you ask them, are you having thoughts of harming yourself or someone else? And if they say yes, the very next question is, do you have a plan? And you listen to what that plan is, because you want to know what their plan is, because whatever they tell you the plan is, that's what tells you, how lethal their plan is. And then the third thing you want to find out is if they have access to a means of carrying out that plan. So if their thought is to kill themselves with a gun, do they have access to a gun? Let's keep going. Does the patient have demographic risk factors? What are the demographic risk factors? You have to know them. Being male, being between the ages 14 to 24, coming from a low socioeconomic status, having little to no support systems, and having had prison time. All of that makes them at higher risks. Aggression by patients occurs most often in the context of limit setting by the nurse. What does this mean? I made a little note down here. It said, make sure you always have an exit route. Never turn your back to the patient. You better always make sure that you know where the exit is, and there is a clear path to that exit, that you can get to that exit, and you can get the other patients to the exit if need be, and you better never turn your back to that patient. That patient is showing you symptoms of hostility or anger or aggression, and you need to get to that exit. You better be walking to that exit backwards. You're walking back like this, and the whole time your eyes is on the patient, because if they swing on you, you're going to have to duck, right? You're going to have to dodge, right? So your eyes need to be on that patient. You never turn your back to that patient. All right. Let's go to psychosocial interventions. It is essential, as in muy importante, to acknowledge the patient's needs, regardless of whether the expressed needs are rational or possible to meet or impossible to meet. You still have to acknowledge your feelings. You still have to acknowledge that perceived need. It's equally as important to clearly state your expectations for the patient's behavior. I understand that you're upset, but it is not allowed to throw things. So you're going to acknowledge how they feel, but you still have to let them know their limitations and their what's expected from them. Okay, look at this. For example, I expect that you will stay in control. I expect that you will keep your hands to yourself. Approach the patient in a controlled, non-threatening, and caring manner. Let me explain what this means to you. You're going to speak to them in a regular tone. So they're acting the fool. They're screaming. They're threatening to kill everybody on the unit and blah, blah, blah. You're not going to raise your voice to meet theirs. You're going to keep your voice calm, because in order for them to hear you, they got to calm their voice down for them to hear you, right? You're going to stay in a calm manner. You're going to make sure you're always facing them. You're going to make sure you keep eye contact with the patient. You're going to make sure that they can see your hands. So when your hands are down by your sides, they're going to be open though. You never have your hands behind your back, because in their mind, you got a knife or you got a gun or you have something to harm them if you keep your hands behind your back. So your hands are going to be open at the sides where they can see. And if you're walking towards a patient, you're going to walk in a normal pace. You're not going to rush up on them or you're going to get clocked, right? That's what the book means when they say non-threatening. Let's keep going. If you're experiencing fear, you may find that this is quite challenging. Maintaining a calm exterior while your interior is in an upheaval requires considerable self-discipline and will come with experience. Patients who are at risk for violence need much more personal space than those who are not. They may take you getting into their space as you threatening them, okay? Allow the patient enough space that you are perceived as less of a threat. Always stay 1 foot farther than the patient can reach with the arms or legs, because you never know when they may decide to try to harm you. So whatever their reach or their grasp is, make sure you're 1 foot farther than that. Be sure you left yourself an escape route if necessary. And that is why I tell you, you better know where the exit is, and you better make sure there's a clear path to the exit. Okay. If necessary, make sure that the patient is not between you and the door. You don't want them blocking you in. Excuse me. Let's keep going. While you're giving the patient space, the patient may be invading your space with verbal abuse and profanity. As uncomfortable as it may be, you cannot take the patient's words personally or respond in kind. So if that patient says, I'm going to knock you out, as much as you want to tell them, come try it and see what's going to happen, you can't say that. You absolutely cannot. You cannot take it personally. This is part of their pathology. It's part of their disease, guys. So you have to remember that, and you cannot take it personally, and you cannot respond in kind. It's also important not to end the conversation because of the patient's verbal abusiveness or to forbid the patient from communicating in this way. You always want to encourage communication, because let me tell you something. If they're thinking about stabbing you in the neck with the pencil that's over there, you want to hear it, right? You don't want it to be a surprise. So you want them to express themselves, but you need to make sure that you're safe at all times. You need to make sure that the staff and the other patients are safe at all times. You want to still make sure that you create these boundaries and you express what the expected behavior is, but you're not going to shut off that communication because you don't like what you're hearing. That's what the book is saying to you. When anger is escalating, a patient's ability to process decreases. So the angrier that they become and the more aggressive they become, the less they're able to process their thoughts and emotions, the less they're able to process sensory stimulation. Okay. The cognitive function decreases as the anger and aggression and hostility increases. That's what they're saying here. So because the cognition decreases, it is important to speak to the patient slowly and in short sentences using a low and calm voice. Never, ever, ever yell, but continue to model controlled behavior. As their level of anxiety is increasing, they're not able to process thoughts as well. So you want to keep your sentences short and to the point. Okay. Use open-ended statements and questions such as, you think people are treating you unfairly, rather than challenging statements such as, what is going on right now? And you know what? I don't like this example they gave as, you think people are treating you unfairly, because that's a yes or no question. That's actually a closed-ended question. Something that would be better to say to that patient is, tell me about this unfair treatment that you think you're experiencing, or that you feel you're experiencing. That is an open-ended question. Okay. But the point is here is, guys, you want to stay away from challenging their delusion. Okay. Avoid ending statements with okay, because it may give the impression that choices exist. So you don't say to the patient, I want you to stop throwing chairs, okay? Because when you say okay, you're actually giving them a choice. What if they say, no, that's not okay, I want to keep doing it? So you're going to make the statement of what your expectation for them is, and that's what it is. Identify the patient's options and encourage the individual to assume responsibility for choices made. You may want to give two options, such as, do you want to go to your room or to the quiet room for a while? So guess what? Either or, you're leaving this environment where you're being threatened to everybody else, but I'm giving you a choice. Do you want to go to your room or do you want to go to the quiet room? So even though you're keeping everyone safe, you're de-escalating the situation, you're still giving them a choice, and you're still allowing them to feel like they have a choice. And look what I wrote up here. Give clear options. One or two, which one do you want? This approach decreases the sense of powerlessness that often precipitates violence. Look at this. Pay close attention to the environment. Choose a quiet place to talk to the patient, but one that is visible to staff. You don't want to be cornered off with the patient, and here they are knocking your lights out, and you have nobody to help you because nobody can see what's going on. This is the most beneficial part in helping a patient regain control. Staff should know you are working with the patient, keep an eye on the interaction, and be prepared to intervene if the situation escalates. At this point, move other patients away as much as possible. Let me stop right there and we'll keep going. When you get a test question about a patient that is escalating and they're starting to be violent, or you can tell they're about to be violent, and the question is, who do you move? So let me give you an example. A patient, they're being violent, they're throwing things. Do you move that patient or you move everyone else away? If they're already being violent, guess what? You need to move those patients away because you have to protect your patients. But if you have a chance that patient's starting to escalate and you see like this isn't going to go well, then you can move your patient away. But if they're already being violent, at the end of the day, safety comes first. You're going to move the patients. Okay. So look what it says, move other patients away, and as much as possible, remove any objects in the area that can be used as a weapon. Now, before I go into the consideration for staff safety that you need to know, let's look up here. Signs, symptoms, diagnoses, and outcomes for aggression. I'm going to focus on these signs and symptoms you guys have to recognize. Look at their body language. And guys, notice we're seeing the same thing again and again and again. And what did I tell you about when authors communicate the same concept to you? That means you're going to see it on a test. Make sure you know it. So what are we looking for? Rigid posture, clenching of the fist and jaw, hyperactivity, pacing, history of violence, impulsivity, suicidal ideation. Again, you're going to ask them if they have the thought. And if they do, you're going to ask them if they have the plan. And if they do, you're going to ask them, or find out if they have access to, the means of carrying out that plan. Difficulty with performing simple tasks, poor problem solving, verbalizations of inability to cope, anger, impatience. Okay. Now let's go over the considerations for staff safety and make sure you know them. There are 6 basic considerations. What are they? 1, avoid wearing dangling earrings, necklaces, scarves, anything that they can wrap their hands around and pull you down. Okay. 2, ensure that there's enough staff for backup. Look at this. Only one person should talk to the patient because we don't want them to feel threatened. So you only want one person talking to the patient, but everybody else should be keeping an eye out on that interaction so they can intervene immediately if need be. But only one person so that they don't feel threatened and their hostility and aggressiveness doesn't, escalate even further. 3, always know the layout. Always know where your exits are. Always make sure that there's a clear path to your exits. Okay? Correct placement of furniture and elimination of obstacles and hazards. You don't want a couch right in front of one of the exits where if you need to make a quick exit, it's blocking the way. 4, do not stand directly in front of the patient or in front of the doorway. That can be considered confrontational. Okay? It's better off, look at this, to stand off to the side and encourage the patient to have a seat. And if they have a seat, you have a seat too. Because if they're sitting down and you're standing up talking to them, that can be considered as, what's the word I'm looking for? Confrontational, like you're trying to take them on. Okay, you always want to be eye level with them. 5, if a patient's behavior begins to escalate, provide feedback. Something as simple as an observation. You seem very upset. And don't say anything after that. And they'll say, yeah, I'm upset, XYZ. But you're getting them to explore their feelings. You're getting them to talk about how they feel or what's going on with them. And then number 6, avoid confrontation with the patient either through verbal means or through a show of support with security and guards. Again, one person with that patient, unless more people, including security, has to intervene, but never has security there as backup to show them that you're outnumbered. All you're going to do is escalate. And we're trying to de-escalate, okay? Verbal confrontation and discussion of the incident must occur. Look at this. When the patient's calm. So if something does happen, don't even bother discussing it with the patient until they have calmed down and they are in a place where they can think rationally and look back on what happened, and they can talk about how they were feeling during that time, and you guys can start planning goals. Next time, they start to feel those anxious feelings or those feelings of anger or hostility or whatever it is that they were feeling, how they can recognize it and how they can behave differently. But you can't have those discussions while that patient is still at 100, right? You want to do it while they're at 1, where they can actually think clearly. And those are the 6 considerations for staff safety. So guys, this was number 1 in our multiple part series of anger and aggression. So please let me know in the comment section what you guys thought about this video, what you'd like to see me cover more of or more extensively. Don't forget, Sundays, 1 p.m. Eastern Standard Time, every Sunday, 1 p.m. Eastern Standard Time, I release a video where I go over nursing questions. I teach you how to answer the questions correctly, and I teach you how to avoid or eliminate the wrong answer choices. Don't forget, I have audio lessons available on my website at nexusnursinginstitute.com. Thank you so much for watching this video, and you guys will catch me on the next video.